Thank you very much for the very kind introduction. I didn't recognize myself there. So, I was given this title, Recent Advances in the Treatment of Depression, and I have modified it slightly because I'm going to focus predominantly on pharmacological treatments. So I will mention some non-pharmacological aspects, but I'm not really going to be focusing on that to any great extent. I am going to be talking a lot about drugs. These are my disclosures of interest. The point at the bottom in red is the most important thing because I don't hold any ongoing financial relationship with any pharmaceutical company. So I'm going to divide this presentation into three bits. Firstly, a reflection on the recent past. Secondly, look at some cutting-edge psychopharmacology. And thirdly, make the sort of non-pharmacological points that it's not what you do, it's the way that you do it, as the song goes. So I'm going to start with the first, and I'm going to make 2 points. One is that we can sometimes recognize important things from old strategies, but the other thing is to also remain open-minded, as Frank Zappa would have us, and always question issues around efficacy of the treatments that we use. So the first point, to do with recognizing strategies from the past, is that we have known for many years that the use of antipsychotics to augment antidepressants can be helpful for some patients with treatment-refractory depression. In days gone by, a favoured antipsychotic for this was thyroidazine. People were using thyroidazine to augment antidepressants 20 years ago or more. Now, thyroidazine is no longer available. But we've learned that the second-generation antipsychotics can also play a similar role. And this is a meta-analysis published back in 2007. It's getting a bit dated now. But it listed a number of studies with olanzapine, risperidone, and quetiapine, most of which were actually negative. But certainly looking across the board of all of these studies, there was a significant advantage with a very respectable numbers needed to treat of just 4 to 5. So this did certainly raise the notion that atypical antipsychotics could be useful augmentation agents. And indeed, we now have quetiapine licensed for this indication. This is one of the studies that supported that license, which is the placebo-controlled study of quetiapine in doses of 150 and 300 milligrams per day, demonstrating benefit. These were in patients who had failed to respond to at least one antidepressant, or failed to get an adequate response. Now, when that data was first published, Michael Bauer from Germany also showed this data on a poster. And it is quite interesting because it compared in the dark pink lines augmentation with quetiapine with the black line, which was augmentation with lithium, which many people would regard as the gold standard. And there was a significant advantage of quetiapine. And when I first saw that, I went, wow, this is the only study that I'm aware of that suggested an advantage of one treatment over another in treatment-refractory depression. However, all is not what it seems, because Michael Bauer was able to demonstrate that the plasma level of lithium was very important, so that patients who had plasma levels of at least 0.6 did significantly better than patients whose plasma level was below 0.6. And if you just compare those who have a level of at least 0.6 with the patients treated with lithium, there is no difference between the treatments. So it suggests the treatments are equally efficacious as long as we use lithium appropriately with an appropriate level. Now, quetiapine has a license. The other antipsychotic with replicated positive randomized controlled trials is aripiprazole. Aripiprazole is not licensed in Europe. It is in the United States. It isn't licensed in Europe because of a lack of longer-term data, but it does have replicated positive studies as shown here. So that was remembering something from the past, the utility of antipsychotics in the management of depression. Now I want to raise questions to do with efficacy. For some time now, more than a decade, many of us in clinical practice have been using combinations of antidepressants to manage patients with refractory depression. And this was on the basis of studies such as this, very small studies, 11 versus 15 patients treated with mirtazapine or placebo in addition to an SSRI. And there was an advantage of the mirtazapine. So a lot of people got very interested in this. More recently, we've had a larger randomized control trial, 25 plus patients in each group, comparing fluoxetine plus mirtazapine, venlafaxine plus mirtazapine, bupropion plus mirtazapine with fluoxetine. And all of the combinations were significantly better than fluoxetine only arm, supporting the notion that combinations are efficacious. But over 50% of these patients, this was first-line treatment. These were not treatment-refractory patients. Now, to my mind, that is an important issue, but I still believe that this is important data demonstrating the combinations work. However, the largest combination study by far, with over 200 patients in each treatment arm, comparing escitalopram with bupropion plus escitalopram versus venlafaxine plus mirtazapine, showed no difference in response or remission rates of any of the treatments. So this is the largest combination study, and it is negative. However, note that 44% of these patients had developed depression before the age of 18, and well over half had been depressed for more than 2 years, many of whom had failed a number of different treatments. So a very different population compared to the previous study. So question marks regarding the efficacy of combination antidepressants. The other question is to do with the use of lamotrigine. Lamotrigine has been used in treatment refractory depression on the basis of its efficacy in bipolar depression. However, there are now at least 4 randomized controlled trials of lamotrigine, and if you look at this column, the second from the right, every single one of them was not significant on the primary outcome measure. And the largest study, not enormous, 96 patients, it was negative on every single outcome measure. So the evidence does not support lamotrigine augmentation in unipolar depression. So that's the reflections on the past. Let me move on to cutting-edge pharmacology, look at a novel antidepressant, focus on different neurotransmitters aside from 5-HT and norepinephrine, which is where all antidepressants to date have been act on, and also have a look at a couple of things that we've been looking at treatment-wise based upon findings of pathophysiology in depression. So the first thing is a novel antidepressant. Vortioxetine is an antidepressant that is being launched by Lundbeck. It is an interesting antidepressant. It inhibits uptake of 5-HT, norepinephrine, but also has effects on a number of 5-HT receptors, including being a 5-HT1A agonist and a 5-HT7 antagonist. This is one randomized trial that it's been studied in when it was compared with venlafaxine, and there was similar effects of both the vortioxetine and the venlafaxine compared to placebo. Nothing particularly surprising or great or stunning from that. But this is the sort of data that is intriguing people about vortioxetine. This is animal data. This is based on rats who have been depleted of 5-HT, and which leads to cognitive impairment. So here we have 2 different cognitive tests. Here we have the control scores. The first bar to the right is when they've had their 5-HT levels depleted. If they are then treated with either escitalopram or duloxetine, there's no significant improvement in cognition compared to the depleted state. So these are the two conventional antidepressants compared to the depleted state. However, treatment with vortioxetine on the far right leads to a restoration of cognitive function. So there is an intriguing question as to whether this drug will help patients with depression, not just with regard to mood, but also cognitive function. Now let me move to other neurotransmitters, and the first one I want to mention is dopamine. It is the neglected monoamine with regard to the management of depression. This is a randomized controlled trial of the stimulant modafinil used for narcolepsy, which enhances dopamine function. There are now replicated randomized controlled trials demonstrating benefit of modafinil augmentation of antidepressants in refractory depression, particularly patients with excessive fatigue or sleepiness. So this points to a potential benefit of targeting dopaminergic function. Following on from that, there have been studies of the drug pramipexole used in Parkinson's disease, and it is a dopamine agonist. Pramipexole has been studied in open studies in both unipolar disorder, shown here, and in bipolar disorder, showing benefit of improvement in mood. Now, it still needs to be tested in a randomized controlled trial, but it is something we have used in our clinic with some success with some patients. So it does suggest dopamine should be explored further. The other transmitter I want to mention is glutamate. This is the hot topic, the hot area in depression research. And it is all based upon this study from Carlos Zarate from 2006 showing efficacy of intravenous ketamine. There is no doubt that intravenous ketamine improves mood acutely in depressed patients. There are now many studies showing this. The problem, though, is the benefit of a single dose is short-lived. And at this moment in time, nobody really knows the answer as to how to maintain this response. One possibility is repeat treatment with ketamine, but the how to do that and the safety of doing that remains an open question. In terms of other lines of research, thinking about pathophysiology in depression, we know glucocorticoids are raised, cortisol is raised, so there are some positive data for anti-glucocorticoid treatments. We've recently conducted a large study of metyrapone, but that unfortunately was entirely negative. So it remains an open question as to whether this is a fruitful area to explore. Folate levels are also often found to be low in depression. There are two studies of L-methylfolate, one positive, one negative. It remains open. We also know inflammatory cytokines are raised in depression, so people have studied non-steroidal anti-inflammatory drugs such as celecoxib. Here are 4 studies of celecoxib, a meta-analysis suggesting benefit. But although there are 4 studies, it was a total of only 160 patients. They were not refractory. It is unclear whether this only works if people have raised cytokines. And at the moment, we don't know about the safety of giving, or how long to give this, and the safety of giving celecoxib, given concerns regarding cardiac risks of celecoxib. So not something we are doing clinically yet. So finally, let me go on to very quickly say it's not what you do, it's the way that you do it. And I want to make 3 points. The first thing is, do not delay. The duration of untreated depression is important. Patients with a short duration of untreated depression in the dark bars do better than those with a long duration of untreated depression. So get on and treat patients if they justify being given treatment. The second point is, treatment by algorithm is better than treatment as usual, even when treatment as usual is by experts following guidelines. The issue, though, is what algorithm? And that, I think, has to be individualised to your individual patient, certainly with refractory patients who had a myriad of different drugs for different durations at different doses. But this effect is bigger than any single drug. And my final point is instill hope. Treating depression can be depressing. We know only a proportion of patients respond or remit. Many don't. And if we look at second, third, fourth line treatment, response remission rates are going down. However, if you add all of that together, most patients do get better. So do not give up. Keep going, look for alternatives. So my conclusions are, there is good evidence for quetiapine and aripiprazole augmentation in refractory depression. Lamotrigine is probably not effective, and the efficacy of antidepressant combinations is unclear. Vortioxetine is an interesting new antidepressant with positive effects on cognition. Dopamine treatments may be helpful, and there is good evidence for modafinil augmentation. IV ketamine works acutely, but long-term use is uncertain, and other treatment options are under investigation. And it's very important to understand it's not what you do, it's the way that you do it. Don't delay, treat by algorithm, and don't give up, instill hope. Thank you very much indeed.